connections, and we do not take note of the intermediate situation. That is different when we are dealing with the situation in which both arterial valves are overriding, because it is this intermediate arrangement when both arterial valves that are overriding that produces the arrangement that we're going to describe for you today, and what we would like to call double outlet both ventricles. Now, we have not invented the term double outlet both ventricles. In fact, if we go back and we look at the history of this lesion, we can go all the way to the middle of the 1970s. And at this stage, this excellent article appeared by the late Peter Brandt. Peter Brandt was a radiologist, and he was working with the New Zealand team at that time at Green Lane. Sir Brian Barrett-Boys was the surgeon. Louise Calder, John Noitzi, pediatric cardiologist, an excellent team. And Peter Brandt was a superb radiologist. And he noted at that time that there was this spectrum between double outlet right, double outlet left ventricle. And in this paper in which they concentrated on double outlet left ventricle, they suggested that this intermediate arrangement could be called double outlet both ventricles. So as far as we know, this is the first time in which this term was used. Then my very good friend Anton Becker, working with Maki Ueda when she was in Amsterdam with him in the middle of the 1980s, he and she came across a couple of hearts which showed this arrangement that Peter Brandt had called double outlet both ventricles. And they discussed this in the setting of the classification of hearts in which both arterial valves were overriding, which is what we are going to be discussing further today. We also made reference to this entity, although we did not place much significance on it, but we did describe it when, together with Pierre Aiello and Diane Spicer and my developmental colleagues, we discussed the components of the outflow tracts, what we call the infundibular building blocks. I'm going to show you some of those pictures today. But the thing that has concentrated my mind on double outlet both ventricles was the invitation I kindly received from KRISHNA IYER, who is going to be presenting later this afternoon on the diagnosis and the surgical treatment of this entity. He and his colleagues were kind enough to ask me to join them when we emphasize the importance of this definition in the diagnosis and the surgical treatment of this particular entity. So as I say, that is what we are going to be discussing today. And so I am going to try to set the scene. And I'm going to do this in two ways. In the first instance, I'm going to be discussing with you development. And I'm going to try to persuade you that there is a good explanation to explain why both of the arterial valves might be overriding the crest of the muscular ventricular septum. And I'm going to move on from that, and I'm going to show you the basic anatomical arrangement that KRISHNA and his colleagues came across in their experience in India. So let me take you back to the starting point of cardiac development. Those of you who have been watching our presentations would have seen this before. You know now that I depend upon my understanding of what's going on in the developing heart by the availability of these magnificent interactive PD files. And they have been made by my good friend, Professor Wout Lammers, and his colleague, also a good friend of mine, Dr. Jill Hickspoors, and they work in the University of Maastricht. And they have made these interactive PD files covering the key points of cardiac development in the human heart. So this is an early stage. As you see, it's what we call Carnegie stage 13. CS stands for Carnegie stage. And this is about 5 weeks after fertilization. And what you see is that at this early stage, the atrioventricular canal, the way out of the developing atrial chambers, is supported exclusively by the developing left ventricle. At this stage, the apical part of the left ventricle is ballooning from the inlet part of the ventricular loop. So the apical component of the right ventricle is ballooning from the outlet part of the ventricular loop. And the developing right ventricle at this stage is supporting the outflow tract, and the outflow tract is extending to the margins of the pericardial cavity. So what we need to know if we are to understand double outlet, both ventricles, is what is happening to the outflow tract. So let me show you what's happening to the outflow tract at this early stage. I'm going to switch here to the development in the mouse, but I'm going to show you very shortly. It is a similar situation in the human. So here I've sliced off the front of a developing mouse heart halfway through the 12th day of murine development. So there you see the outlet part of the right ventricle, and you'll remember that the outflow tract is supported exclusively by the right ventricle at this stage, and it extends to the margins of the pericardial cavity. And already by this stage, non-myocardial tissues have grown in to fill the distal part of the outflow tract. And that non-myocardial distal part is being separated by a protrusion that is growing from the back wall of the aortic sac. And it is the growth of this protrusion that is dividing the non-myocardial distal outflow tract into the intrapericardial components of the arterial trunks. The remainder of the outflow tract retains its myocardial walls, but we can recognize a middle component, and we know that that middle component is separated by the distal parts of the cushions that spiral during normal development through the remainder of the outflow tract. The proximal outflow tract is then being separated by the proximal part of those cushions, and as yet, these proximal cushions have yet to fuse. They have fused in the middle component, and they are dividing now that middle component into the developing arterial roots. As I say, it is the same situation in the human heart as in the murine heart. So here I'm showing you a later stage. About half a week has passed on since I showed you that early stage as reconstructed by Wout and Jill. But this now is an episcopic data set showing you the similar situation that we saw a moment ago in the murine heart. So there again is the non-myocardial distal component, and this has developed a little bit further. So you see that now already the distal outflow tract is separated into the intrapericardial components of the aorta and the pulmonary trunk. You can also see rather nicely now how the middle component has indeed been separated by the fusion of those distal outflow cushions. Also in this middle part now, we have what we call the intercalated valvar swellings, and it is the interdigitations between these intercalated valvar swellings and the major cushions that form the primordiums of the arterial roots. And then we see proximal component with its outflow cushions, but as yet, in this proximal part, the cushions have not fused. And I'm going to emphasize this fusion of the proximal cushions because it is that process that is key to determining what we see in the setting of double outlet, both ventricles. But let's just stay with the middle part for a moment, because if we move on a couple further stages in the Carnegie staging system, another 3 or 4 days have passed by this stage, and you see now that within the middle part of the outflow tract, the two arterial roots have separated one from the other. And the distal part of those outflow cushions are now cavitating to form the arterial roots. But it is what happens in the proximal part of the outflow tract that determines the connections of those arterial roots. And it is the connections that are key for understanding double outlet, both ventricles. So what I've shown you thus far is that the aortic root, like the pulmonary root, when it's first formed, is supported above the cavity of the developing right ventricle. So how does that root become committed to the developing left ventricle so that in the normal situation, we have concordant ventricular arterial connections? Well, I can show you that by taking this reconstruction again here now from a mouse heart. And this exquisite reconstruction was made again from an episcopic data set. It was made by another of my friends and colleagues, Simon Bamforth, senior lecturer in developmental biology in the University of Newcastle. And what you see here in green is that Simon has shown you the extent of the pericardial cavity. And there now in the middle of the outflow tract, we see the development of the cushions that is forming the aortic root. You can also see distally we have the intrapericardial component of the aorta, and at the margins of the pericardial cavity, it becomes continuous with the extrapericardial aorta. Already at this stage, however, the middle part has been separated into the aortic root, pulmonary root. But what Simon has also now reconstructed in this demonstration is the proximal part of those cushions, because the proximal part of the cushions are now fusing so as to connect the aortic root into the left ventricle, separating it from the infundibulum of the right ventricle, which is the other part that is developed from the proximal outflow tract. And if we look inside a data set at this stage of development, we can see exactly what's happening. Because there is the aortic root. It is positioned above the cavity, the right ventricle. It's separated from the pulmonary root by the fusion of the distal cushions. But there you see the proximal cushions. And as yet, the proximal cushions have not fused together. They are going to fuse, however, and they are going to build a shelf in the roof of the right ventricle so as to commit the aortic root through the interventricular communication to the left ventricle. And this is a stage a little bit later in the mouse heart, 1 day later, when those cushions have fused. But you see, the aortic root is still above the cavity of the right ventricle. But the proximal cushion and the septal proximal cushion have now fused together, and they have built this shelf in the roof of the right ventricle, and that is turning the interventricular communication into the outflow tract for the left ventricle. And that is because, like the cardiac surgeon, the embryo creates a shelf in the roof of the right ventricle by fusing together those cushions so as to commit one of the arterial roots to the left ventricle. And this is the key. In normal development, it is but one of those arterial roots. And of course, it is the aortic root. But what is it that determines that it is the aorta that is to be committed to the left ventricle? So here I've stepped back 1 day again in murine development. It's a different data set, and I've made my cut here through the attachment of the septal outflow cushion. So there you see the cavity of the developing right ventricle, the pulmonary root, the aortic root are separated by the attachment of that septal cushion. But what you can also see is that the septal cushion is attached at the cranial margin of the interventricular communication. And it is this attachment of the outflow cushions to the cranial margin of the interventricular communication that commits the communication itself to the developing aortic root. So that commitment by the cushions to the cranial part, the interventricular communication, prepares the aortic root for its transfer. But in normal development, this also depends on what happens to the cushions themselves. Because in normal development, as we see in this histologic section, through aorta, there you see the aorta, there you see the pulmonary trunk. They've developed from the non-myocardial distal part of the outflow tract. In this histologic section, we have cut across both cushions because they are spiraling within the outflow tract so as to commit the aortic root to the interventricular communication. But we have other mice, and we know that in these other mice, by knocking out the gene for PITX2, knocking out that gene commits these mice to the Tausig-Bing malformation. And the thing that determines the connection of the aorta to the right ventricle, the pulmonary trunk to the left ventricle, is parallel rather than spiraling fusion of those proximal outflow cushions. And that commits now the pulmonary root to the interventricular communication. And by virtue of that parallel arrangement of those cushions, the septal cushion is now attached caudal relative to the interventricular communication, meaning that as the shelf is built in the roof of the right ventricle, the pulmonary trunk is transferred to the left ventricle. But what happens if the cushions fuse neither to the caudal nor the cranial components of the interventricular communication? And in fact, we know that that can happen because we also have a series of mice in which my good friend and colleague Tim Mohan, who prepared these data sets, perturbed the furin enzyme. And this is one of those mice in which he perturbed the furin enzyme. And what you see here, you're looking again at the cavity of the right ventricle. There you see the aortic root. There you see the pulmonary root. And the perturbation of the furin enzyme in these mice has meant that the outflow cushions themselves have fused, but they are hypoplastic and they have not muscularized. And now they have connection neither to the cranial nor to the caudal part of the interventricular communication. And because of that lack of anchoring, both of the arterial roots are now free to move across that embryonic interventricular communication. And this is the key feature that determines double outlet from both ventricles. So when we have the outlet septum formed from those proximal cushions that lacks an anchorage, both arterial trunks can be transferred to the left ventricle. And now if we move from our developmental considerations and we look at the definitive morphology, we see that that is exactly what happens. Because here I'm showing you an example of double outlet right ventricle in which the defect is in subaortic position. You'll recognize that that is the aorta. You can see the coronary arteries arising from the sinuses of this arterial root. It's side by side relative to the pulmonary trunk. There you see the interventricular communication. It's opening, as it usually does in the setting of double outlet right ventricle, to the right ventricle between the limbs of the septomarginal trabeculation or the septal band. And there you see the muscularized proximal outflow cushions. And in this setting, muscularization of these cushions forms the muscular outlet septum. And clearly, you see, it is attached to the cranial margin of the embryonic interventricular communication, and that is committing the interventricular communication to the aortic root. And this is the essence of double outlet right ventricle with a subaortic defect. Let's compare that to double outlet right ventricle with a subpulmonary defect. There again, you see the aorta is parallel and rightward relative to the pulmonary trunk. And once more, you see the interventricular communication. Now, as in the arrangement when the defect is subaortic, the interventricular communication still opens into the right ventricle between the limbs of the septomarginal trabeculation or the septal band. But the key difference is that the muscular outlet septum is now attached to the caudal margin of the interventricular communication. And it is the attachment to the caudal margin that leaves the interventricular communication looking directly into the pulmonary trunk. And in some circumstances, the pulmonary trunk can ride that interventricular communication, as we see in the tau sigma spectrum, with the other end of that spectrum being transposition. But what happens if the outlet septum does not muscularize and retains that freedom in the space above the interventricular communication? And that is exactly what we see here in double outlet right ventricle with a juxta-arterial defect. Because there towards the back you see the aortic root. It is overriding the crest of the muscular ventricular septum. There is the pulmonary trunk, and its root also is overriding the crest of the muscular septum. Both arterial roots are overriding the interventricular communication. Why? The interventricular communication still opens into the right ventricle between the limbs of the septal band or the septomarginal trabeculation, but in this instance, the outlet septum has not muscularized and it is free floating. In fact, it is it is perpendicular to the crest of the muscular ventricular septum. It is anchored neither to the cranial margin nor the caudal margin, and it is this lack of anchorage that permits both of the arterial roots to ride the crest of the muscular septum, giving us what we would now like to call double outlet both ventricles. And here is another very nice heart. This is one of the hearts from that we used in this presentation on the building blocks of the infundibulum. Because this time you are looking at a frontal section through the interventricular communication. So there you see the aorta, there you see the pulmonary trunk, and you see that the outlet septum is fibrous, grossly hypoplastic. There is the crest of the muscular interventricular septum, and both arterial roots are riding the crest of the septum. So now with this juxta-arterial defect, it is doubly committed. You see that the right ventricle can look into the pulmonary trunk through the defect. The left ventricle can look into the aorta. And it is this arrangement that permits the surgeon to partition the juxta-arterial defect such that the left ventricle can be connected to the aorta, the right ventricle can be connected to the pulmonary trunk. And Dr. IYER will be telling you exactly how he's able to do that in the setting of this lesion. So what I hope I've shown you the developmental background that permits the outlet septum to develop in such a way that it is attached neither to the cranial nor the caudal margins of the interventricular communication. It is that feature that gives both arterial routes, the capacity to be transferred to the left ventricle. But what we are talking about today is that intermediate situation where there is overriding of both arterial routes. And I do believe this is very well described in terms of double outlet, both ventricles, and that is now what Dr. IYER is going to be discussing with you in terms of its diagnosis, more importantly, its surgical correction.
Thank you, Dr. Anderson. Sasha, can I proceed?
Yes, please. Perfect.
So, very good day to you all. First of all, I'd like to express my thanks to the Congenital Heart Academy, Sasha and Grace, for the very kind invitation to participate in this webinar with Professor Anderson. I first met Professor Anderson almost 40 years ago at a small town in Erice in Sicily, when a workshop on basic aspects of cardiac surgery was being conducted, and I was a young cardiac surgical resident there. And Dr. Anderson at that time gave the first lecture on cardiac morphology. And it was a mesmerizing talk. And to this day, I remain mesmerized by his talks all the time. The story of double outlet of both ventricles has a bit of an origin from a cardiac morphology workshop that took place in 2018 at the All India Institute of Medical Sciences in Delhi. And during the discussions there, this was a group photograph taken at the end of that session, and you can see Dr. Anderson right in the middle there and me standing in one corner. But it was during the discussions in that workshop, and especially the discussions on double outlet right ventricle, that, as he mentioned, that in situations of double outlet right ventricle with a ventricular septal defect that was committed to both arteries, usually the outlet septum was rudimentary or fibrous in nature, which allowed the ventricular septal defect to be committed to both of the great arteries in the setting of double outlet right ventricle. And at that time, I happened to mention to him that I had seen a couple of cases where the outlet septum was not really fibrous, but was muscular. And the ventricular septal defect did appear to be committed to both ventricles. And he did mention that it was possible and suggested that I'll look into it a little more closely if I got more cases. Sure enough, in the next couple of months, I had another case which intrigued me. The interventricular communication was clearly not the usual one that would see in a double outlet right ventricle. And certainly there was a very prominent outlet septum between the two great vessels. And so I sent a mail to him and the crude drawing of what I had seen and what I had seen in the earlier cases too, and asked him what his opinion was on this lesion. And at that point of time, I described it as double outlet both ventricles, not knowing that this had been, the term had been described earlier. So I wrote to him asking his opinion on this unusual entity, which at that point of time I wrote, said that I have named this double outlet both ventricles for lack of any other description. And of course, he promptly wrote back saying that the entity did seem to fit in with this, but I was not the first one to use this term, and that the late Peter Brandt had already described it way back in 1976. So when we looked at further literature, we found a couple more articles, which Professor Anderson has already referred to, which did describe this entity of double outlet both ventricles. However, all the earlier descriptions were morphological description from autopsy specimens. Peter Band's first article was, of course, on the clinical aspects and surgical aspects of double outlet left ventricle, with a suggestion that some instances could be classified as double outlet both ventricles. So Professor Anderson suggested that we should collect a case series and try and describe the clinical features and the surgical aspects of this condition. And that was how the article, which is labeled double outlet both ventricles, morphological, echocardiographic, and surgical considerations, was finally prepared and published in the European Journal of Cardiothoracic Surgery late last year. I would at this point of time like to acknowledge the contributions of all my colleagues in cardiology, in intensive care, and in anesthesia, and especially Dr. Ankit Garg, who did a lot of the research and collection of data in this article. So what exactly is the clinical spectrum known as double outlet both ventricles? So the key question that we asked us was, what are the diagnostic features of double outlet of both ventricles, and what's the best surgical strategy for this? And this was based on a case selection of 7 patients who we felt had characteristics that fitted this morphological entity. 6 of them had a successful intracardiac repair. 1 patient didn't undergo surgery. And the take-home message was that we were describing the morphological characteristics of the condition of double outlet of both ventricles, along with the echocardiographic and surgical considerations. So the entire study was based, as I said, on a series of 7 patients. As you can see from this rather crowded slide, all patients were of necessity infants, because this is essentially a lesion which is associated with increased pulmonary blood flow, but the intracardiac mixing results in cyanosis. So almost uniformly, all these infants presented with cyanosis, tachypnea, and failure to thrive. A couple of them actually presented in the neonatal period because of associated lesion. One had a coarctation of the aorta, and the second one had multiple ventricular septal defects with additional dysplastic tricuspid valve causing tricuspid regurgitation. So 2 of these 6 who underwent surgery were actually operated upon in the neonatal period. So what exactly is the underlying pathology in this? So this is a cartoon which sort of depicts what exactly we find both on echocardiography and at surgery. Now, as Professor Anderson described, that here is a situation where there's a prominent outlet septum which separates the aortic and the pulmonary root. But this outlet septum does not fuse with the margins of the interventricular septal defect or the interventricular communication. So when that happens, the interventricular communication doesn't have a clear-cut circular margin, and you have a situation where both the right ventricle as well as the left ventricle outflows could communicate with both the great arterial trunks. If you look at it in cross-section, this is what it would look like. You have the 2 great arteries, and they're straddling the crest of the interventricular septum. And the outlet septum, as mentioned, stretches across in a cross manner. The ends of the outlet septum do not fuse with any portion of the interventricular septum. And this results in a situation where both the great vessels override both the ventricles, giving the situation which we call double outlet both ventricles. Now, we now recognize this fairly quickly on echocardiography. In the first couple of cases, it was quite confusing to us. But if you take a plane which runs parallel to the interventricular septum, you can see the superior margin of the interventricular septum, the huge scooped out interventricular communication, which extends from one border of the heart to the other. And in the center of it, exactly at cross-section, lies the prominent muscular outlet septum, which cuts across at right angles, with the aorta lying to the right and the pulmonary artery lying to the left. If you take a cut exactly at right angles to this is what you see. You can see the prominent muscular outlet septum cut in cross section, the pulmonary artery lying on one side, and you can see the crest of the interventricular septum. So the outlet septum is exactly at right angles to the crest of the interventricular septum. So this is a fairly classical diagnostic feature. And what's more interesting is that when you move the probe towards different subcostal planes, you get an appearance which ranges from a double outlet right ventricle to transposition to double outlet left ventricle. So this is an anterior sweep. And if you look at it, the left ventricle, pulmonary artery, and aorta, both the great vessels appear to be committed to the left ventricle, giving a picture of double outlet left ventricle. If you come to the middle of the septum, you can see that the two great vessels appear to be parallel to each other and connected to discordant ventricles. So this gives an impression of transposition of great arteries. And if you move to a further anterior sweep, you can see that both the great vessels now appear to be committed to the right ventricle. So in the same patient, the different views, it would appear like a double outlet left ventricle, a double outlet right ventricle, or a transposition. And this is very clearly seen in this loop. As you sweep the probe from one end of the crest of the interventricular septum to the other, you can see that the great vessels are dancing from a position of a double outlet right ventricle to a double outlet left ventricle. So that's the interesting aspect about this. So what happens when you look at it at surgery? So this is a picture of one of the neonates who underwent surgery. As you can see that the great vessels are almost appearing to be in the normal position, somewhat parallel, but the aorta is to the right and a little posterior, the pulmonary artery left and a little anterior. The pulmonary artery is significantly dilated because it's an increased pulmonary blood flow situation. But the other interesting aspect is that the right ventricle appears to lie in a more horizontal disposition. The entire anterior surface of the heart is right ventricle, and it gives the impression that the left ventricle lies immediately below the right ventricle, unlike the usual leftward position of the left ventricle. And this is in difference to what you see in a classical double outlet right ventricle with a subaortic VSD. This is a picture just to show for comparison. In a double outlet right ventricle, usually you can see a marked dextroposition of the aorta. The aorta is very prominent, lies anterior. The pulmonary artery lies in a more posterior leftward situation. And this is not what the picture we see in double outlet both ventricles. And this is what we see in a Taussig being heart. Again, the vessels might lie parallel and side by side, but usually the pulmonary artery tends to lie a little posterior to the aorta lies anterior. So the external appearances are significantly different from double outlet right ventricle. And when you look inside in the classical double outlet right ventricle, the ventricular septal defect has definite margins in all cases. And any surgeon who has done a fair number of patients of double outlet right ventricle would be able to immediately recognize that the ventricular septal defect has definite margins. But interestingly, the situation in this, what we call as double outlet both ventricles, the VSD is something which is very, very different from what you see in a normal double outlet right ventricle. So if you look in this is the image in a neonate with double outlet both ventricles. And you can see here that this is a very prominent outlet septum here. The aorta is in this region just below this retractor. And that's the margin, the superior margin of the interventricular septum, the crest of the interventricular septum. As you can see, that's extending from one end near the tricuspid valve and goes across all the way to the far end of the heart. You can see there. And that's the pulmonary outflow which lies in that. So you can see here that this outlet septum does not meet the interventricular septum at any point. A still picture of that to show it better. You can see that that's the outlet septum running in a crescentic fashion, exactly at right angles to the superior margin of the interventricular septum. The interventricular septum extends from the proximal near the tricuspid valve and goes all the way to the base of the pulmonary valve there. And the outlet septum extends from the free wall of the right ventricle anteriorly and goes on to the free wall of the left ventricle posteriorly. You can see the anterior extent of the outlet septum. You can see it merges with the free wall of the right ventricle. It does not meet the crest of the interventricular septum. Likewise, the posterior extent of the outlet septum, again, it merges with the free wall of the left ventricle posteriorly. It does not meet the interventricular septum. So when we come to surgery, the surgical options for a double outlet right ventricle are fairly well defined depending upon the location of the VSD. If it's subaortic, it's a simple intracardiac left ventricle to aorta tunneling. If it's a pulmonic VSD, one would do a tunneling of the left ventricle to the pulmonary artery and an arterial switch procedure. And then if it's a doubly committed VSD, depending upon the great vessel relationship, one could do either of the above. But in this situation of double outlet, both ventricles, it's somewhat different. Now, one could theoretically tunnel the left ventricle to either the pulmonary artery or the aorta. But obviously, if we tunneled it to the pulmonary artery, then we'd have to add an arterial switch operation, which would have been technically more challenging given the position of the great arteries, as I showed you in the picture earlier. So it would be more logical to tunnel the left ventricle to the aorta and at least avoid performing an arterial switch operation. But the problem was that if we tried to use a single patch for this, then the patch became very complicated and twisted in the middle because the margins of this interventricular communication were quite tortuous. And we did that in the first two cases and ended up in a series of problems. Both of those patients had to have resurgery because of patch dehiscence, because obviously the patch was under great tension. The other learning was that in the first two cases, we also divided the prominent muscular septum, thinking that that would allow us to have a more straighter pathway between the left ventricle and the aorta. That again, in retrospect, seemed to be a mistake because in one of those patients, there was a patch dehiscence and the suture had given way at the site where we had resected the septum. So then the surgical technique evolved that we thought that the most logical way to do it was to do it with two patches. So the first patch is a triangular patch, which was interposed between the crest of the distal interventricular septum and the posterior margin of the pulmonary artery. That in effect closed the path from the left ventricle to the pulmonary artery, allowing the right ventricle to be connected to the pulmonary artery. So when you place that patch, essentially now it converted the defect into a double outlet right ventricle with a subaortic defect. And then the second patch would conform to the usual intracardiac tunneling of a double outlet right ventricle with a subaortic VSD. So the combination of the two, then the two patches were sutured at the area where they were adjacent to each other. And this now complicated closure of the interventricular communication resulted in the left ventricle being diverted to the aorta and the right ventricle remaining connected to the pulmonary artery. So just a few video clips to show. Now this is the triangular patch that we use, which is inserted to the distalmost portion of the interventricular communication. I'm sorry, it's difficult to see because this is a neonate and you can see the magnification is huge. But just to give you an idea, that's the patch that we used to close. And once you place the patch in between, you can see that anteriorly is the inlet into the pulmonary artery, which will be connected to the right ventricle there. And here now is the subaortic residual defect, which is communicating with the left ventricle, and the aorta is here. And once we put a patch here, that completes the repair and allows the left ventricle to be tunneled into. So that's what we're doing. This is a second patch, which is being sung after sutures have been placed along the posterior inferior margin of the defect. This is the patch now which will tunnel the left ventricle into the aorta. And once this patch is placed, the two patches are sutured side by side. And once that is done, that completes the rerouting of the left ventricle to the aorta. So as I mentioned, of the 7 patients, 6 underwent surgery. All 6 had intracardiac tunneling of the left ventricle to the aorta. In 4 of them, it was with 2 patches. In the first 2, we used a single patch, but as you can see from here, both those patients required reoperation for patch dehiscence. And however, all of them did leave hospital alive and well. As we got better with the diagnosis and management, the hospital stays reduced. But nevertheless, this is still a condition because it presents in either the neonatal period or early infancy, and the intracardiac surgical patch as well as the surgical steps are quite exhaustive. These patients do go through a period of significant low cardiac output, and they require fairly meticulous postoperative intensive care. Nevertheless, all these patients are doing well on follow-up. The longest follow-up is 8 years now. All of them have no significant residual outflow tract obstruction, either of the right ventricular outflow or the left ventricular outflow. A couple of patients have minor residual shunts in the ventricular septal defect. And the patient, the neonate who had significant tricuspid regurgitation, who required a tricuspid valve repair in addition, has still a residual moderate level of tricuspid regurgitation. It's a couple of echo pictures to show the postoperative follow-up echos. As you can see, the fairly decent unobstructed left ventricular outflow tract, and this showing a nice right ventricular outflow tract which has no obstruction. So to summarize, I'll just put up the slide of what we wrote as the conclusion there. That to conclude, we have presented our clinical experience with the ventricular-arterial connection, which we suggest is best described as representing double outlet of both ventricles. We suggest furthermore that this entity should be incorporated as a discrete type of connection in the overall classification of disorders of ventricular-arterial connections, as it has important surgical implications. The morphology is readily identified on cross-sectional echocardiography, and good surgical outcomes may be anticipated by following the 2-patch technique that we have described, followed by meticulous intensive care. Thank you very much for your attention, and I'll be happy to answer questions.
Thank you. It was very nice, and I've learned a lot. I need to tell that I've never seen one patient like that, or maybe we had this patient and we didn't name that way. Okay, so Dr. Silverman, can you comment on that?
Well, yes, I was just going to say the same thing as you. I think that it's important to be able to recognize this condition, because if you can't recognize it, you're going to put it in a classification that is inappropriate, and then the surgeon is going to have to look at this from his point of view in order to be able to repair it adequately. I can agree with you that I have never seen one of these conditions, but I would add exactly the same caveat that you added, that maybe I have seen it but not recognized it. So that really is the important issue. I think, Dr. Iyer, that was a beautiful description. I'm sorry that we didn't get a chance to look at the videos in great detail as you made them. But the pictures were very, very clear. Dr. Anderson, the question that your talk again was, as Dr. Iyer had said, was breathtaking. What I wanted to know is, in the development of the spiral septum, it would seem the way you've described it, that the division of the septum occurs first at the distal end and then proceeds proximally. That is somewhat different to what I think Dr. Danny Goer and the surgeon's name is just slipping me at the moment, that described initially in 1973 about the development of the spiral septum. I wonder whether you could perhaps just re-emphasize these points for us.
Well, you're entirely correct that, in fact, it's now well established that septation of the outflow tract does occur from distal to proximal. There are two septal components involved, and this is the important point, that as I have not recognized that until relatively recently, but it is fascinating. If you go back and you look at the account that was given by Julius Tandler as long ago as 1913, Julius Tandler explains in exquisite detail how there are these separate septal components and how they partition the outflow tract, starting at the level of the aortic sac and moving towards the right ventricle. In fact, it's very difficult to understand what Tandler was discussing because his pictures are not brilliant. And Wout Lammers and I have been discussing this, and Wout makes the point that he must have been a brilliant embryologist because nobody else can understand what he was talking about. But he seems to have worked it out. And it is the case that the distal outflow tract is separated by what we can now call the aortopulmonary septum. That grows in from the dorsal wall of the aortic sac, and then the cushions themselves divide the middle and the proximal parts of the outflow tract. So it's a three-part procedure. First of all, the aortopulmonary septum grows in. That fuses with the distal cushions that fuse with each other. So the aortopulmonary septum separates the intrapericardial aorta from the pulmonary trunk. The distal cushions separate the arterial roots one from the other, and then the proximal cushions subsequently fuse, and they create the shelf in the roof of the right ventricle, and they do exactly what Krishna has just shown that he does. They create that tunnel that puts, in the normal situation, the aortic root into the left ventricle, in the setting of transposition, the pulmonary trunk into the left ventricle. And if those proximal cushions do not fuse, then you get the situation of double outlet, both ventricles. And then, as Krishna showed you so beautifully, he then uses two patches so as to connect that interventricular communication so that the left ventricle runs up into the aorta, the pulmonary trunk runs into the, takes its origin from the right ventricle. I thought Krishna's presentation was absolutely exquisite. I had forgotten our exchange that we had subsequent to the AIMS meeting. So thank you for reminding me of that, Krishna. And I'd also forgotten that I met you first in Erice so long ago, 40 years ago. That's going a very long time back. So thank you also. Happy memories. We had a great time in Erice, and it was a wonderful meeting.
It was memorable. All the great legends of this, from Bob Kirkland to Francis Fontaine, Jan Quagga.
Jerry Brom was there, as I recall.
Jerry Brom was there, Mike Tynan, Jane Somerville.
Indeed. It was at that wonderful monastery that it was a little hair-shirty, but we had a good time.
Well, I would like to echo Bob's remark, Dr. Iyer, about your presentation. I thought it was so clear. And the morphology is so easy to see both on the ultrasound and on the actual surgical examples that you showed. But Bob, I don't want to let you go on this because, you know, people like Dr. Patton, the late embryologist, and even Dr. Gittenberg de Groot have shown that the rotation that occurs in development of the pulmonary artery, which the great vessels, the pulmonary trunk is posterior and rotates and spirals to become anterior. How exactly does this happen on the inside in terms of the spiraling of the division of the cushions? Have you
Well,
got some?
I don't think that is correct, in fact, Norman, because from the outset, at the first stage at which we see the pulmonary root separated from the aortic root, it's in its definitive position. So this notion that there is spiraling during development is not true. In fact, the spiraling occurs much earlier, and that produces the arrangement of the outflow tract that I showed you at that early stage. When it takes, it's entirely muscular at that stage. There is rotation at that stage, but then the separation of that outflow tract into its component parts, it involves no more spiraling. The spiraling is already there, and it is the way that it is separated into the two components that produce, and it's the interaction. It's almost like what KRISHNA did with his two patches, because he used the two patches. He used the one patch to close off what was going off the left ventricle, and then he used the other patch. And the embryo, to a certain extent, does that also. The interrelationship between the aortopulmonary septum and the septation produced by the cushions themselves, that is replicating in a way what KRISHNA was doing in correcting double outlet both ventricles. So this notion that you said Professor Schittenberger de Groot put forward of what she calls the pulmonary push, that I can see no evidence to support that whatsoever. From the time it's first seen, the pulmonary root is where it ends up. It's superior and it is leftward relative to the aortic root. There is then more incorporation of the aortic root into the left ventricle, but the pulmonary root is always where we see it in the definitive heart.
So in transposition, as you described, with the parallel development, this occurs extremely early.
Correct, correct. And it's the positioning. It's, in fact, you could argue that it is the original position of the outflow tract itself that dictates that the cushions will not spiral. And that also, there's evidence of that. That was described a long time ago by Okamoto, who was working in Japan at the time. And he talked about a straight loop rather than a spiraling loop. So it's that very early stage that probably sets the scene for transposition.
And it's in the muscular mid portion of the developing outflow tract that occurs. Is that correct?
Well, it's the alignment of the cushions one to the other that arranges it in such a way that the pulmonary trunk ends up looking into the left ventricle rather than the aortic root.
Okay. Well, I wanted to make those points because they certainly been a concern for me, but I think that there must probably be a concern for many of the other listeners to this presentation this morning. So thank you very much, Bob, for that.
When Sasha and I were recording this, I pre-recorded my presentation. KRISHNA did a magnificent job with presenting his material directly to you, but I pre-recorded mine, and Sasha made the point when we were recording it that it takes a long time to get the developmental work into context, and we'll continue to do that. I thought that the combination of what I did today and how KRISHNA backed it up was quite superb. And I think this is what we're going to try to achieve as we move onwards. We're going to try and correlate what we see during development with what we see in morphology, and hopefully set the scene for the sort of thing that KRISHNA has been doing. You'll have noticed that Alan McGee commented congratulating KRISHNA on his presentation. Alan is going to be with us in 2 weeks' time, and we're going to be talking about critical aortic stenosis. We hope to do exactly the same sort of thing with Alan presenting the clinical aspects of what we're doing. And this is going to try to be the focus of what we're going to do on our future Fridays. But KRISHNA has done a wonderful job in setting this up for the future.
Yeah.
We are very happy with this new series, and the feedback has been amazing. We have more than 200 people watching live on Zoom and more on YouTube now. For those who are on Zoom, I have a question for the audience. Sasha, can you make the poll, please? So, have you ever seen a patient with double outlet double ventricle? yes, no, or now that you've seen this presentation, maybe you remember about one that maybe was this, but you didn't know on that time. Can you please answer?
The
Yes,
question, Grace, maybe should be, have you ever recognized a patient with double outlet both ventricles?
Yeah,
That's
yes,
amazing
exactly, that's
that
it.
In no time at all, Krishna has put together 7 of them, so they do exist.
Yeah, sure. So I'm really curious because we have an audience from all around the world. So I'm really curious to see how people would answer this question. And we have a lot of interesting questions on the Q&A chat box. It's going to be a very interesting discussion.
Sorry, Bob, I want to underline the importance of Erich in this meeting today, because Sicily was in the middle between you and Krishna, and Erich is an amazing place. So we are very happy that sometimes, you know, beautiful place make a beautiful thought and make happens fantastic experience. It's interesting.
Perhaps Erich is not quite as beautiful as Taormina, Sasha, and the restaurants were much better in Taormina than they were in Erich.
But they are in the same island.
It's interesting that Dr. Pranav just type on the Q&A chat box. He's greeting us, you about the presentation, and that he had one identical case that now he realized that was double outlet, both ventricles.
But I think that the answer from the poll is interesting now.
So let's see. It's not showing, not for me.
Yes, sorry.
Okay. Yeah, very, very interesting.
How about that? How about that? Isn't that interesting? So there you are, Krishna. You brought something to our attention. Isn't that interesting?
Yeah,
So
this is something that we should spread this presentation so more people would be aware of this entity. And this is not about the nomenclature. This is about the change of the surgical approach. So this is very important.
Right.
And it's Krishna, you can comment on this, because when you moved from the 1-patch to the 2-patch technique, it became so much easier, did it not?
Yes, and it basically evolved from the concept that Barbara Marshall had described the multiple patch technique for the double outlet right ventricle with non-committed ventricular septal defect, using sort of 3 patches in order to prevent twisting of the intracardiac tunnel. And so it sort of became an extension of that, because I realized that trying to shape a single patch into a complicated curve was creating problems. So that's when the idea occurred that we probably 2 patches would be better. We often use 2 patches in certain other situations, especially in corrected transposition when we're doing the double switch, or the Senning-Rastelli procedure. And if it's a long path from the left ventricle to the aorta, it often makes more sense to use 2 patches and join them together in order to prevent a twist. So some extension of what we've used in other situations that worked out here.
And Adrian just joined us. Hi, how are you?
Hello, how are you? Thank you.
Questions.
Yes, very interesting presentations. Thank you. I just wanted to clarify a few things. First of all, is not that the outlet septum has to be hypoplastic or fibrous in these cases. I understood from Dr. IYER that quite a few of the cases he described have actually a well-developed muscular. It's more about the perpendicularity between the outlet septum and the muscular interventricular septum that is interesting. And then the position of the right ventricle. He mentioned that it was more anterior with a left ventricle that was, I don't want to use crisscross or this type of topsy-turvy, but that is another interesting term. And I don't know from Professor Anderson how many such specimens he saw in collections around the world. Thank you very much.
It's interesting that I do have. I made the point that, in fact, Vera has a very interesting heart with exactly the same situation that Krishna showed. But in the hearts that I have, it was much easier to show the size of the interventricular communication in the setting of the fibrous outlet septum. It's much more obvious to me in the setting of the fibrous outlet septum. I've seen two with the muscular septum, as Krishna described. All of yours had a muscular septum, Krishna?
Yeah, absolutely. All 7 of them, and that is the distinguishing feature. Now, I don't recall whether we missed cases where the outlet septum was fibrous and we sort of treated it just like a doubly committed ventricular septal defect. But this morphology is very striking, and if having seen this, if anybody next sees the next case, I'm sure they will immediately identify it as double outlet both ventricles.
Yeah.
But as rightly pointed, the hallmark is the right angle or the cross-sectional appearance of the outlet septum and the crest of the interventricular septum.
Very nice. We have some questions from the audience. A lot of people asked about 3D image or CT scan, MRI, if you guys think that this would help the diagnosis.
Yeah,
3D
actually,
printing.
When we got around, as I said, the last 2 cases were neonates who were really not in a position to be shifted. They're both on the ventilator, was not in a position to be shifted for more advanced imaging. But certainly the next case, and this was also the question from the reviewers when we sent this for publication, whether we had any 3D imaging but we promised to do that for the next case that comes in, and we'll have a look at that. I'm sure 3D imaging and maybe what Dr. Saurav Gupta is doing and trying to create virtual 3D images will give us a much better picture of what we are seeing.
Dr. Krishna, let me just ask you a question about the oxygen saturations in these patients. What have they run? Have they run with mixed mixing, arterial mixing, or they predominantly acyanotic or predominantly cyanotic?
As I mentioned, they were all cyanotic, but not deeply so. So they were all in the range of 85 to 90% on room air. So pretty much like a transposition with a large ventricular septal defect.
And Dr. IYER, I've seen you use the patch. One was autologous pericardium, probably treated. What was the other one? Did you use any curved baffled patch?
Yeah, I curved the second patch for double outlet right ventricle for most of them. I curved the patch on a Hagar dilator and I fix it in glutaraldehyde. So you get a nice curved patch which you can put. So it doesn't show up very clearly on the video, but it's actually a curved patch. And just
okay, and you had no conduction problems in this case?
No. The conduction bundle is well protected because the posterior inferior margin is all muscular.
Okay. So we have one question from a perfusionist from Malaysia. Thanks for being with us. He's asking if any of your cases required ECMO or mechanical circulatory support, and if there's anything different that should be done on perfusion.
Not really. Yes, the initial couple of cases did have a prolonged cardiopulmonary bypass time because we were still trying to figure out what the anatomy was. But subsequently now, no, the cross clamp times are well under 1 hour and none of these patients required mechanical support.
Okay, very nice. And Carlos Troconis is asking, can DORF with a double committed VSD be considered double outlet both ventricles?
I think that's a very good question. I think somebody else has posed that question. And this is what I was getting at when I talked about these spectrums, because in the spectrum of the riding of the aorta, the spectrum of the riding the pulmonary trunk, we choose to give the overriding vessels to one or the other ventricles. The point here is we're choosing not to. And when both of the arterial routes are overriding, which they typically are, if you have a doubly committed defect, I think in my experience, it's because there's nothing to anchor the routes, as Krishna showed you, the outlet septum goes from the front to the back, the ventricular septum goes side to side. So there's nothing to anchor the arterial trunks between the roots. And also the point he made, when you do that sweep, you can either make it double outlet left ventricle, you can make it double outlet right ventricle. So to me, I think this is the situation where rather than giving the overriding roots to one ventricle or the other, we should accept that it's an intermediate situation and hence double outlet both ventricles. So I wonder whether double outlet right ventricle with non-committed defect, doubly committed defect rather, is going to become double outlet both ventricles. I mean, this is something that I've not seen any of the, I've not seen any hearts for quite some time, but this is something that all the clinicians are going to have to think about. I mean, Krishna, would you still think that you could have double outlet right ventricle with doubly committed defect, or is it going to be double outlet both ventricles?
I think the clinching fact would be, as I said, the echocardiographic sweep. If in that same patient, you're able to show 3 images showing double outlet right ventricle transposition and double outlet left ventricle, like I showed, then that would clearly be double outlet both ventricles. And I think the echocardiography plays a more important role in demonstrating the connections rather than surgical, because surgical with the arrested heart and with the heart collapse, you may actually imagine one or the other vessel. The extent of overriding is not all that much clear as it is in echocardiography. So to my mind, for a double outlet both ventricles, the echocardiographic demonstration of the swing from a double outlet right ventricle to a double outlet left ventricle would be the most important factor to make the diagnosis.
I think the point you make also about the fact that you can see it better in the clinical situation also applies to the autopsy room, because it's very difficult in the autopsy room to judge the degree of override. And it's also, previously I've made the mistake when thinking the outlet septum is fibrous, it is automatically going to be doubly committed. And I know that that now is not the case, because you can have a fibrous outlet septum as you have with the so-called Mexican TET, and the fibrous outlet septum commits the interventricular communication to the aorta. So I think we're really going to have to reconsider the way we diagnose double outlet right ventricle with doubly committed defect. I mean, Norman, you must have seen these at ECHO, and would you have thoughts about that?
Well, Bob, as I said, I'm in the group that probably hasn't seen them. I just looked at my classification, and I don't have a classification for double outlet both ventricles. So I have never classified anything in that direction. I've just corrected that error, and the classification now does contain double outlet both ventricles. And, you know, when I see this again, I will certainly bring it to everybody else's attention, because I'm sure it's not as uncommon as you thought from what the survey shows. My problem is, of course, if you don't understand it, you can't recognize it. And I think that today's presentation has clearly shown us that it is both a recognizable and a definite entity and can be appropriately repaired.
Absolutely.
There are several questions about associated lesions. So have you seen hearts with hypoplasia of the ventricles with arch anomalies, CCTGA? So there are questions about that, which associated lesions could be possible with this entity.
Well, 2 of these patients, as I mentioned, one had a severe coarctation of the aorta in association. We repaired the coarctation in the same sitting. And the second patient had multiple ventricular septal defects. In addition to this, they had an inlet ventricular septal defect and multiple mid-muscular defects, and also a dysplastic tricuspid valve with tricuspid regurgitation. So these are the only 2 patients who had associated defects. You know, all the others, except for a patent ductus, patent arterial duct in one patient, no other significant associated malformation.
I would be amazed if we're not going to see cases with pulmonary stenosis as well as coarctation, because I think that with the muscular outlet septum, that's likely to be malaligned one way or the other. And I think, presumably in your case with coarctation, the muscular outlet septum was partitioning the outflow tract at the expense of the pulmonary trunk.
It is a question about the George's syndrome or the 22q11 deficiency. Dr. IYER, have you done chromosomal analysis and
we didn't do it. We do it only on suspicion. I wouldn't be able to tell you whether we did it in any of these patients, but clearly none of them had any clinical suspicion of genetic abnormality. We haven't done chromosomal analysis as a routine in these patients.
Well, I think that would be an important thing to look at worldwide, because there's no reason why many of these patients shouldn't have that kind of anomaly.
True.
Dr. IYER, if I may go back, because this is really important and we are concentrating a lot on the outlet septum, but I was again very impressed by what you said in terms of the perpendicularity of the two septums and the rotation of the right ventricle. Do you think that that plays a role in having that interventricular muscular crest in a different position comparing to the outlet septum?
I think the horizontal position results from the defect rather than causing the defect. So as you can see, essentially, that there is an absence of a right ventricular outflow in the true sense that, you know, the subpulmonic infundibulum in this situation is absent because the outlet septum is in a totally different orientation. So that results in a setting where both the left ventricle and the right ventricle look almost identical. But one is placed on top of the other. I hope you understand what I'm trying to get at. So even if you look at the cross-section and the echocardiography, I mean, you've got two ventricles with a septum in between and nothing on top except the roots of the great vessels.
We can't describe proper infundibulums in this case.
Well, they're not circular infundibulums.
It's a good point you raised there, Adrian. I think that, and Krishna, correct me if I'm wrong, we didn't concentrate really on whether there are bilateral infundibulums, did we?
Well, the problem with this is that whenever you imagine an infundibulum, you imagine a cylinder. And here, both great arteries are subtended by structures which are not entirely cylindrical, because you have an outlet septum in one plane and you have the interventricular septum in the other plane. So it's on one side, the aorta is in close approximation to the tricuspid valve, and on the other side, the pulmonary artery is far distant from the mitral valve. So you really can't clearly define an infundibulum as we know an infundibulum to be classically. It doesn't give the appearance of infundibulums, although both arteries are subtended by entirely by muscle.
Okay.
I have a question as a surgeon. So I understood that your first diagnosis was on the table.
Yes. When the first diagnosis was confusion.
Yes. Oh, it's really
only by about the third case
how
that
the surgical recognition is still central in this new field, in new diagnosis. And I'm surprised that the experience from Norman, he never met a case like this. Probably it doesn't look in this way. And again, the third consideration is probably it's very difficult to make diagnoses like this in neonates. So we need to wait or symptoms or the child that grow to 6 months to 1 year to better define this particular area. What do you think?
I think another point, Sasha, is that a lot of the diagnosis we make depends on whether we have a pigeonhole in which to put the diagnosis. And as Norman made the point in his classification, there was nowhere to put double outlet both ventricles. Now you know that is a possibility. I am sure we're going to see many more. I mean, for Krishna to have collected, what, 8 years, Krishna, you saw, 8 years ago, you saw the first one.
Yes.
Yes.
So
Well,
over
I
8 years,
would like to-
there's nothing crazy. I mean, the volume of patients in India is truly spectacular. But for Krishna to have collected 7 cases in 8 years, I mean, that's not coincidence.
No, I want to underline how the surgeons are more clever than cardiologists. This is
Well, there you go. I think maybe I disagree with you.
Mute his microphone, please. Let's mute his microphone.
Can I just make a point, Sasha, that to disagree with you respectfully?
Thank you, Dr. Norman. You can do that, please.
Surgeons are smarter than cardiologists, and cardiologists are not as smart as embryologists. But the pointed issue that is important that you made for the audience is, I think, if I would look at all double outlets, which are perhaps the most confusing and difficult entity to define, is that in the neonate, one has exquisite opportunity to obtain the picture of the malalignment between the outlet septum and the ventricular septum. And I think particularly of doing this from a subcostal view and looking at this and rotating the probe round so that you can put the probe in the alignment of the outlet septum, as well as then rotating the probe around to show the alignment of the ventricular septum. And I think, Dr. Iyer, you showed that very clearly in your pictures. And I can't see that that would be difficult in a neonate. I think that would be easier in the neonate when subcostal imaging becomes less exquisite as the patient's age. In an older patient, it may be quite difficult to do that. But I think in the neonate, this would be really easy to do. And I think that's where one should focus one's attention, especially in the Western world.
I should give credit to our cardiologists, because the initial lack of not fitting into a normal pattern was picked up by the cardiologists, because we have the joint discussion. Then in any situation where it appears to be a double outlet right ventricle, they'd usually like to show me images as to the rootability of the left ventricle to the aorta. In the first case, they said, well, this left ventricle is definitely rootable to the aorta, but then it's also rootable to the pulmonary artery, so I don't know what you're going to do. So we said, well, we'll have a look in the table and decide what to do. So we actually went in prepared for an arterial switch along with the VSD closure. But once we opened the right atrium, then I felt, well, it is certainly rootable to the aorta in a complex sort of way. And then I felt I should route it to the aorta rather than to the pulmonary artery. And we did end up in a mess in the first couple of cases, because as I mentioned, the patch turned out to be pretty complicated and tortuous, and ended up having to be revised in one patient, had a patch dehiscence in the other. So, but after the third case, we were sort of pretty clear what we were dealing with, and the subsequent cases were diagnosed on echocardiography, and we were pretty sure what we'd find on the table.
Sure. Your surgical pictures were outlet pictures. Did you do a ventriculotomy to see the position? How did you approach surgically the outlet views that you showed?
Through the right atrium, that's so you can visualize.
Through the right atrium, everything was done through the right atrium.
That's right.
Well, that's amazing.
You don't need a ventriculotomy.
Okay, we are going to finalize with one last question, and then we need to give only our final thoughts. So Dr. Paulo from Brazil is asking that as the images that you showed, the aorta was anterior in relationship with the pulmonary artery. So if you have seen different arrangements, or is only this, or always this way?
It has always been this way. All 7 patients had an almost similar morphology.
Okay. So
What
guys,
about stenosis? How do you handle
We
that?
might see separate relationships between the arterial trunks. We see them in other situations. I think there's no uniformity, but I think this is what Krishna has shown is the general pattern.
So guys, thank you very much. It was.
Can I just say, correct me if I'm wrong, Krishna, but it's India Day today, is it not?
No, it's Republic Day was 26th last week when you
Oh,
were.
so it wasn't. Oh, that was what. Sorry, I thought you were with us on Republic Day. I was going to say we're particularly thankful to you for that, but I hope you had a good Republic Day.
Yes, it was. It was quite a grand affair, despite the COVID.
That's good.
Sorry, there was a question about pulmonary stenosis. How do you handle the situation if there's pulmonary stenosis? Have you ever seen that in this situation?
Seen it, and my guess would be that this entity is not conducive to producing pulmonary stenosis.
Mm-hmm.
I think the
Okay.
position
Well,
of the
if it does, they end up in the autopsy room at the moment. We shall
Well, there you
see.
go.
We shall see.
I think we're going to learn much more about double outlet both ventricles now Krishna has brought this to our attention.
That's
Sure,
right.
sure.
It'll be interesting to see that.
Thank you.
Guys, thank you very
you.
much.
Thank
Hope
you
to see you all next Friday. And please subscribe to our YouTube channel and share this presentation if you found it interesting to all your colleagues. Thank you very much, guys.
Bye, everybody.
Bye.
I'm very happy. Thank you, Krishna. You demonstrate very important.
Bravo.
Yes.
Bravo.
Thank you, Sasha. Thank you, Dr. Silverman.
Thank you, Sir Krishna.
Now he's working on LinkedIn. We are asking to the people how many cases they are looking with double outlet both ventricles. So we will update you.
Probably have about
Talk to you on Tuesday, Thursday.
Okay. Bye.
Norman.
Bye.
Bye. Ciao.
Ciao, ciao.